to present our data on GBT440. I'm going to set the scene a little bit because it is important to understand the mode of action of this drug. So, as you all know, sickle cell is caused by a single amino acid substitution at position 6 on the beta hemoglobin molecule. This leads to the production of hemoglobin S instead of hemoglobin A. When hemoglobin S deoxygenates, it forms long hemoglobin S polymers, which lead to the formation of the sickle cells. These sickle cells, when they traverse through the microcirculation, cause vaso-occlusion and infarction, and you're well aware of the bony crises that we see in many of our patients. This also leads to the acute chest syndrome, which is the leading cause of death in these patients. It also leads to hyposplenism at a very young age due to splenic infarcts, osteonecrosis, and a nephropathy. The hemoglobin S polymers lead to the sickle cells being very rigid, and when they pass through the circulation, we see breakdown and hemolysis. This hemolysis releases free hemoglobin, which binds nitric oxide and releases oxygen-free radicals, which cause further damage to the endothelium and a vasculopathy. The nitrogen oxide functional deficiency also leads to vasoconstriction, and we see pulmonary hypertension, priapism, and various other complications. We know within sickle cell there's also a hypercoagulopathy and a hyperinflammatory state. This is just to remind you that every organ in the body, unfortunately, can be affected by sickle cell disease, and that these complications lead to a 2 to 3 decade reduction in the life expectancy of our patients. GBT440 has been specifically designed to bind to hemoglobin. When it binds, it increases the oxygen affinity of hemoglobin S and inhibits this polymerization, which causes all the problems that I've previously described. So we would hypothesize that patients on GBT440 will see a reduction in the red cell damage, you'll see a reduction in hemolysis, and an improvement in the anemia. With the inhibition of the formation of the sickle cells, we'll also see an improvement in blood flow, and this could potentially modify the course of sickle cell disease in our patients. So this is the summary from the presentation that I'll be giving tomorrow. GBT440 actually increases the hemoglobin levels in the patients. It reduces the reticulocyte count and improves biomarkers associated with hemolysis like bilirubin and LDH, and the biomarkers associated with inflammation. The pharmacodynamic data that we have produced shows a left shift in the oxygen curve into the normal range of hemoglobin A, and this confirms the mechanism of action of GBT440. The hematological effects correlate with the blood levels of GBT440. Pharmacokinetic data has shown a linear and dose proportional properties and a half-life that is amenable to once daily dosing, which is incredibly important in this patient population. We've given the drug in a randomized controlled double-blind trial over 28 days and have seen no serious adverse events. There's a theoretical concern about tissue hypoxia, because if you increase the affinity of hemoglobin S, there's a concern it won't deliver oxygen to the tissues, but we have seen no evidence of this. We've actually seen reductions in the erythropoietin level and the reticulocyte counts, which are consistent with improved oxygen delivery. These are the curves. So on the left, you can see the hemoglobin values. And as early as day 4, you can see quite significant increases in both the 500 milligram cohort, which is in blue, and the 700 milligram cohort is in green. The placebo is in red. And these are maintained over 28 days. Following that, you can see dramatic reductions in the reticulocyte counts, which maximally are reduced by more than 50%, and these are maintained over 28 days. The reduction in the reticulocyte count suggests an improvement in red cell lifespan. There is a suggestion, if you look on the left-hand side of the curve, that between day 22 and day 25, there might be a reduction in the hemoglobin, but I think this is very early data and it's within variance. And also, because of the lifespan of sickled red cells, we would expect an equilibrium to be reached at around 40 or 80 days, and I'm only showing you 28-day data. These are very powerful. This is the blood film of a patient on day -1 prior to receiving any GBT440, and you can see the sickle cells and the boat cells very clearly. This is a patient that was in the 700 milligram cohort, and at day 28 you can see that there are now no longer any sickle cells within this film. There are some target cells and hyperchromatic cells. On the left, you can see the cohort data, and you can see that we see around 50 to 60% reduction in the sickle cell percentages, which is maintained over the 28-day dosing. So in conclusion, we have emerging data at 28 days of dosing, and this supports the hypothesis that this drug inhibits polymerization of sickle hemoglobin. It improves hemolysis, reduces red blood cell damage within the microcirculation, and improves oxygen delivery to tissues. Longer-term dosing is clearly required, and this will define the optimal hematological effects of this drug and the clinical benefits. GBT440 offers a well-tolerated, once-day oral drug with a mechanism-based and potentially disease-modifying therapy for sickle cell disease. The full results of this phase 1/2 trial will be available in mid-2016, and a pivotal trial in adults is planned, a phase 2/3 trial, and a PK study in pediatric patients next year. Thank you.